Good day, everybody. My name is Jolan Walter. I am the Robert A. Good Endowed Chair and Division Chief at the Pediatric Allergy and Immunology Program here at Johns Hopkins Children's and University of South Florida in Tampa, Florida. And today I will share with you a snapshot on WHIM syndrome, which stands for warts, hypogammaglobulinemia, infections, and myelokathexis. So briefly talking about WHIM syndrome, as I mentioned to you, this is an acronym. W is standing for warts. So patients tend to have not only warts, but also HPV-related cancer. H is for hypogammaglobulinemia or low IgG. I stands for infections. It could be both viral and bacterial. And myelokathexis is a special term that we use for the fact when mature neutrophils are stuck in the bone marrow and they cannot really be released and they die in the bone marrow, and therefore there will be a neutropenia in the periphery. When I think of WHIM syndrome, I think about it as an inborn error of immunity. Particularly, it is a disease caused by a genetic defect in the CXCR4 gene. The CXCR4 protein has a nicely undulating transmembrane portion. And then there is a part we call the tail, which is going to transmit the signal of this protein to the inside of the cell. And every WHIM patient that we currently know has a variant or in this region in the tail. And this variant either shortens the tail or it changes the formation, how the tail is actually three-dimensionally creating a signaling tail, and that would make it hard for the CXCR4 protein to work properly. So far, there are 11 known pathogenic variants, and we have genetic testing available to diagnose this disease. But the problem is that there is no approved targeted therapy for WHIM syndrome at this point. There are some therapies available on clinical research grounds, but no targeted therapy in the hands of the doctors in the office. So when you think about WHIM syndrome, you actually think of a few things. One is that not all patients will present with all of the 4 characteristics that I mentioned to you at any given time. And in fact, when you look at the acronyms, the M, the myelokathexis, is what is present in almost all of the patients. This is a very unique finding in the bone marrow. As I mentioned to you, the neutrophils are not released to the periphery and they are over-maturing in the bone marrow. And this over-maturation is reflected by them gaining more nuclei. So it's a hypernucleated neutrophil. And also the neutrophil becomes, the nuclei get connected with a stringy, long stringy filaments. So the pathologist can detect it. But you need to have an experienced eye of a pathologist. And it's not uncommon that pathologists may think it's a malignant process or a myelodysplastic process. So then after that, recurrent infection is the second most common feature of the disease. And we see it already in children. However, hypogammaglobulinemia and especially warts may not present until later in life. So when you think about the syndrome, you really have to take it into account the patient's age and the fact that it can be quite variable within families. Just to reemphasize the fact that this gene defect is actually has an autosomal dominant mode of inheritance. So what does that mean? It means that if either parents carry it on one allele, like mom or dad, as you can see here, this mom had a faulty gene on one of her alleles, she can pass it on to her children in 50% of the time. And she can have the disease and her children can have the disease. So you don't need a second hit here. Having only one abnormal gene on one allele is sufficient to cause the disease. And this is why, again, every generation can be affected. It's still possible that there would be de novo cases when it's not coming from the parents, but the child is developing this variant on its own. And the genetic heterogeneity is also complemented by the fact that There is no genotype-phenotype correlation. So what that means is that just having a genetic defect that would not predestine you for a known clinical disease. Some patients with the same gene defect would have either just warts or low immunoglobulins or neutropenia. So we cannot really tell by the gene defect itself what kind of phenotype the patient will have. And so with all that in mind, you need to probably understand what type of cells are going to play a role in this disease. And of course, the WHIM syndrome is primarily followed by hematologists, and hematologists are experts of neutropenia. So neutropenia is an important feature of the disease, and it is stemming from the myelokathexis that we have discussed, that the neutrophils are stuck in the bone marrow and they cannot get to the periphery. And neutropenia will result on infections. However, besides the neutrophils, there's an increasing interest to understand the contribution of other immune cells to the disease, such as the T cells and the B cells and the monocytes. And we all know, as I'm talking to a very well-versed audience with immunodeficiency, that having B-cell lymphopenia or abnormal B-cell function can easily lead to hypogammaglobulinemia. We also know that having an abnormal T-cell function or even monocyte function can eventually predispose a patient for warts. However, the full understanding of wart predisposition and which cell type is the clear etiology of the disease is still not fully understood. When we think about WHIM syndrome, we really think of a multi-system clinical disease. And the disease would be found easily by looking at very easy biomarkers, such as low lymphocyte count, low neutrophil count, or low white blood cell count. Also, looking at the vaccine titers or immunoglobulin can lead the clinician for this diagnosis. Furthermore, as the patients are aging, they will have a few different types of infectious complications. Beyond the recurrent infections, such as ear infections, sinusitis, or pneumonia, it's not uncommon that patients will develop viral-induced disorders, such as EBV-associated lymphoproliferation, when you have a mononucleosis that is out of control, or treatment-resistant HPV, when you have warts that are just spreading on the hands and the feet, and even in the anogenital area without relief. Interestingly, patients can also have very bad periodontal disease, like having inflammation around their teeth could be a sign and manifestation of WHIM syndrome. And then long term, what has been really disheartening is to see patients evolve into state of cancer. Patients can have lymphoma, they can have skin cancer, and not uncommonly develop persistent changes in the lung called bronchiectasis or COPD. Young children can develop hearing loss, which is another very important key feature of the complications and could point the clinician towards diagnosing WHIM syndrome. So when we think about WHIM syndrome, we have to think about warts, as I mentioned to you. These are coming much later in life. They can affect the hands and the feet of the patients, most commonly again in adults. And interestingly, the type of strains that are affecting the warts are quite unique for WHIM syndrome. And some of these HPV are actually resulting in cervical dysplasia and carcinoma. So it's very important to know which serotypes are affecting your patients and do they have actually some signs of cervical changes that could be linked to the disease. For the hypogammaglobulinemia, as we all know, it is defined by low levels of immunoglobulins, in particular IgG, IgA, or IgM. We do see an association of the low levels with low quality of antibody response, including low vaccine titers, as I have noted here in the middle of the slides. However, it is still unclear which patient will have susceptibility for infections. Not every patient with mildly decreased low immunoglobulin levels will have an infectious phenotype. And it's still unclear where to replace immunoglobulins and where not. However, we must say that around 70% of the patients with WHIM syndrome can develop hypogammaglobulinemia. And if you have the syndrome and hypogam, you should be discussing replacement therapy repeatedly with your physician. The next feature is infections. Infections is highly characteristic of this disease, in particular upper respiratory infections, but even pneumonias, recurrent pneumonias are commonly seen. And because the patients have recurrence of these events, they can lead to end organ damage, which could be hearing loss or bronchiectasis. Infections often begin in infancy and may lead to persistent life-threatening complications. So again, if you have a child with infections, with low neutrophil count and lymphocyte count, it is already a pretty good clinical history for consideration of WHIM syndrome. And then myelokathexis, again, I'm just coming back to this term because it's a complicated term, and you are having retention of the neutrophils in the bone marrow. Because bone marrow biopsy is often not performed for patients, it is sometimes overlooked as a finding in WHIM syndrome. And those who have biopsy performed, the pathologist may not be able to interpret the findings properly. It's highly operator dependent. And therefore, it can happen that myelokathexis is not going to be diagnosed in a timely fashion in WHIM syndrome. So because of the difficulty of the obtaining bone marrow specimens or interpreting it, we really are encouraging physicians and clinicians and parents to consider genetic testing as an alternative mode of diagnosis. However, at this point, myelokathexis itself is the gold standard for diagnosing WHIM syndrome on a histological level. And here I just summarized for you some of the findings on the bone marrow biopsy, which is a little bit technical, but if you have reports, it may help you to understand whether you have clinical features of WHIM syndrome or not in your bone marrow biopsy. In the ESID guidelines from Europe, there is some understanding of how to diagnose WHIM syndrome, and it is primarily based on two factors. One is the low neutrophil count, and the second one is on the myelokathexis that I mentioned to you before. If you have both features and there is genetic confirmation of the abnormal CXCR4 gene, then you can have a definitive diagnosis of WHIM syndrome. However, if you have no access to genetic information, you have to have additional features such as the warts, lymphopenia, the hypogammaglobulinemia, or family history of warts to make a probable diagnosis. And again, we are really promoting now the genetic testing for many of our patients, since the myelokathexis diagnosis could be sometimes difficult to obtain and may not be fully well interpreted. This is an important matter that I wanted to share with parents who have WHIM syndrome or families where there is concern for that we believe that WHIM syndrome may be found on newborn screening in some of the cases. So we have a publication that was led by Dr. Evans and Phil Murphy from the NIH. And in this publication, we looked at the patients who were born in our country during the newborn screening era for SCID. And what we found that among the 6 patients who we could find during the newborn screening era, half of them, 3 of them had low TRK levels. All of these infants were near term and they had no prematurity. 3 of the 6 had no known family history of WHIM syndrome. And all infants had evidence of severe neutropenia at birth. Only 1 patient had normal neutrophil count because at that time he had an infection. So what this tells us is that having a low TRK level on newborn screening in combination with neutropenia should really indicate possibly a clue for WHIM syndrome. And the WHIM syndrome should be considered in the differential diagnosis of abnormal TRK quantification on newborn screening. So in summary, WHIM syndrome is a rare autosomal dominant primary immunodeficiency disorder with no approved therapy. Patients who have CXCR4 gene pathogenic variant will result in WHIM syndrome And that will be manifested by the retention of neutrophils, lymphocytes, and monocytes in the bone marrow, and lead to inadequate immune function, leukopenia, and neutropenia in the periphery. WHIM stands for warts, hypogammaglobulinemia, infection, and myelokathexis. However, this acronym does not reflect the broad spectrum of disease that patients may experience during their life. And again, the WHIM acronym does not reflect the frequency of these manifestations, as the warts are the least common manifestations of the disease. Clinical manifestations of WHIM are associated with significant morbidity and mortality, and patients with WHIM often face delays in diagnosis and misdiagnosis. And therefore, many of us in the field are on a quest to help patients to get diagnosed as early as possible and possibly get to the clinicians in time for proper therapy. WHIM syndrome should be considered in individuals with chronic neutropenia and myelokathexis and confirmed with sequencing of the CXCR4 gene. And although current management is symptomatic, it may not be adequate, and there are substantial burden of disease across all ages, and clinical trials are on the way to help WHIM syndrome to be treated targetedly through modification of the CXCR4 gene signaling. And I'm available for questions. Thank you.